So cataract extraction at the time of keratoplasty, and I have to say for most patients who need a penetrating keratoplasty and who have a cataract, I prefer to do the PK first, and then when suture removal is finished, then do the cataract surgery. But there are cases in which I have to do them together, and I'll show you a couple of videos. This is a patient, for example, a young woman, multiple failed grafts, for whom I'm performing a Boston type 1 keraprosthesis. In this case, if they're phakic, you have to take the lens at the time of the K-Pro surgery. You can't leave them phakic. So these patients are under general with paralysis, always with a Flinger ring, because if they're going to be aphakic at any time during the surgery, I put on a Flinger ring. Your open sky capsulorhexis is always an adventure. I perform it like I do normal cataract surgery, initiate it here with a cystotome, and then I use these micro grasping forceps you'll see in a moment. But in this case, I start small. Start with a small diameter, maybe 4 millimeters, because it tends to spiral out as you swing this around. One other thing is when I'm doing normal cataract surgery, I have no problem just regrasping multiple times. Everything is stable. Here, as you open up the capsule, the contents of the lens start to bulge upwards. And so this surface becomes more and more convex, making it such that that rhexis is more likely to go out. So I would not regrab it more than I've done here, more than maybe 4 times max. If you take too long to regrab, that lens is going to, that rhexis is going to radialize. In this case, she's young. I've got a big rhexis, so I'm just going to hydro express the lens. It's an easy way to take this lens out. As you see, you can do it here. Again, this does not work if you have a smaller rhexis, or if you try to do that, it will cause a tear and radialization of that tear. It also doesn't work if you have a dense cataract necessarily. You see me using the IA here, partly because I'm old school. I do like Simcoe better. Open sky, just easier to see because you get a lot of flow when you use the IA, as you see here. But the Simcoe is not always available. So once you have removed all the residual cortex, now you got to get the lens in. Usually not that hard, but sometimes you'll have a bulging bag. We'll see that in a couple of videos from now, where it's really tricky getting that lens in. I like to reform the bag using a dispersive viscoelastic. So I usually use Discovisc. It stays in there better, keeps that bag open, the equator open more easily. And I always use a 3-piece IOL. This is the Alcon MA60AC. One piece would be difficult to get in because there's the height of those haptics. And in this case, what I can do is put in the leading haptic and the optic quite easily. See, the trailing haptic, though, needs to be sort of dunked in, as you note there. So I'm always pushing down on the optic with an instrument where that haptic optic junction is. So that will kind of lead that initial portion of the haptic into the bag, and then I'll dunk the peripheral portion of the haptic. Remove the viscoelastic that's in the bag, and then bring the pupil down. In this case, like I said, this is a K-Pro surgery, but obviously most time you'll be putting on a PK. Now, things don't always go according to plan. Here's a patient in whom they have a white cataract. So this is much different than the last case. That was a young patient, very soft lens. Here we have an older patient, dense white cataract. This is why I decided to do it at the same time as a PK, because if you do this cataract surgery after your PK, you're going to cause significant cell loss. So if it's ever a very dense cataract, I'll do a combined procedure. Again, the same instruments here, initiate it with a cystotome and then use the microforceps. And I'm doing fine here. The rhexis is controlled, but right here, you'll see, as I'm sort of hesitating a bit, goes out. And as that lens comes upwards, no, I would tell myself, stop. If you keep pulling, that thing's definitely going to radialize even further. So what do? What you have to do is go the other direction. So use scissors, Van Ness preferably, just make a little snip. You see how small that little snip was there? Then that gives you something to grab. This is where these forceps are really helpful. They have very fine control. And then just pull the opposite direction there. Okay, so now we have saved the day and we can complete the cataract extraction.